Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Pho, founder and editor of KevinMD. Today, we have a special sponsored episode on hypoglycemia in partnership with Purdue University College of Pharmacy and the Academy for Continued Healthcare Learning. Despite advances in therapies and the increased use of continuous glucose monitoring, episodes of severe hypoglycemia still occur in patients with diabetes. The good news is that we can make sure that patients are prepared to manage any severe episodes of hypoglycemia. Please visit the tools and a CME quality improvement activity at preventhypotoolkit.org. That's preventhypotoolkit.org. That link is in the show notes. This activity is supported by an educational grant from Lilly. So today, I'm joined by Davida Kruger, a certified nurse practitioner in diabetes at Henry Ford Health in Detroit, Michigan, and Dr. Anne Peters, a professor of clinical medicine at the Keck School of Medicine at the University of Southern California. So both of you, Davida and Anne, welcome to the show.
Good to be here.
So today, let's get started on our discussion about assessing patients' risk of hypoglycemia and preparing patients for severe episodes of hypoglycemia. But I'm going to ask both of you first, just to briefly share your story and journey to where you are today. Davida, why don't you go first?
Hi, I'm a certified nurse practitioner. I've actually been in the role at Henry Ford Health System for the past 40 years, working in the division of endocrinology with people who have diabetes. That's what I do. 100% of the time, I work with people who have diabetes.
And Anne, you briefly share your story and journey to where you are today.
Well, I'm very similar to Davida, in which I've just basically done diabetes management with patients for my entire career, both type 1 and type 2, although shifting somewhat more to people with type 1 diabetes and in particular using technology. But I've also always spent half my time working in a well-served community and the other half of my time in an underserved community. So I'm very interested in how we apply tools and technology to people who are less fortunate, but who need healthcare even more perhaps than anybody else.
And we're going to talk certainly more about those issues and hear about some stories from both of your perspectives. So let's get right into the questions here. So Anne, can you please describe the burden of hypoglycemia in patients with diabetes?
Well, from a patient perspective, I think the burden is huge because people who are at risk for hypoglycemia, which means pretty much everybody who takes insulin and some who are on sulfonylurea agents or other drugs that can make them go low, are always wandering around the planet worried about going low. And when you give insulin, you have to get the dose right. And if you get the dose wrong, and that is often because people's dose will change based on what they eat, how high their sugar is, if they're exercising, if they're stressed, whatever they're doing can change that dose. And therefore, it's always a little bit of a guessing game, and they're always at risk for going low. And I think it makes people afraid. I think it makes people worried about bringing their blood sugar down into the normal range. I think it has a whole host of psychological consequences as well as physiologic consequences for our patients.
So Anne, just to follow up, so patients who go low on their blood sugars, how do they typically present to you in the office?
Well, I ask every patient who is on insulin if they're having episodes of going low. And I also, in general, use a lot of continuous glucose monitoring so I can look to see if they are going low. But I don't think I have a single patient on insulin who doesn't have hypoglycemia. But what I'm really worried about is severe hypoglycemia, when somebody loses consciousness and has to be helped by another to recover. So it's the severe episodes of hypoglycemia that I'm most worried about. But all of my patients have some hypoglycemia. It's just part of the process.
And Davida, what typically causes severe hypoglycemia?
Oh, there's a lot of things that cause severe hypoglycemia. So first of all, I think mistakes. I got a phone call this morning from a family that their 76-year-old father took their 43 units of their long-acting insulin and only 4 units of their short-acting insulin and mixed those two up. So now we have all of this rapid-acting insulin on board, and I'm trying to come up with a plan so that we don't have an assisted hypoglycemic event, which will include monitoring that person's blood sugar probably hourly for the next 6 hours and feeding them. So mistakes in switching your insulin, and people reach into the refrigerator and meaningfully make mistakes. It's human nature. Schedule changes. Patients wake up and they decide they're going to go for a walk, and they end up walking twice as long as they think they were going to walk, and they have hypoglycemia because their body's not used to it. A missed meal, a missed snack, a meeting that runs over. I mean, I could give you 1,000 reasons of things that cause hypoglycemia, but as Anne said, patients are living with hypoglycemia every day. Our job is to teach them how to prevent it so that it doesn't become a severe episode. And you asked Anne a question about what does hypoglycemia look like? That's so individual. We can give you like a half a dozen symptoms of hypoglycemia, but it's sort of like an aura of anything. And patients have their own symptoms, and they have to get used to that. And family members get used to what that person's symptoms are so they can help them when their blood sugars are just low rather than severe that needs assistance.
And Anne, is the incidence of hypoglycemia related, of course, to a patient's glycemic control? And when should a patient's glycemic target be reconsidered to address these episodes of hypoglycemia?
Well, I think that's a slightly complicated question. So in the past, we knew that the tighter the control, meaning the more normal the blood glucose levels, the higher the risk for hypoglycemia. But that was before we had the newer insulins, we had the pumps that talk to sensors. We have a lot more tools, but people still have episodes of hypoglycemia in spite of all of the tools we have. And things that put people at more risk are being older, because as you get older, sadly, it actually gets harder to manage type 1 diabetes. But there are also people who have what's called hypoglycemia unawareness. They lose those warning signals that Davida was discussing, and they're at really high risk. And then if people have recurrent episodes of severe hypoglycemia, you want to change the targets. But the good news for at least me is that if somebody's having a lot of issues with lows and I raise their targets so that I make their lower number 100, so they don't ever go below 100, and then make it so that they don't have to be as tightly controlled, what happens is it will restore their sensing of lows. So there are ways and programs to work on with a patient to get them more aware of their hypoglycemia. And that's where, frankly, having a really good diabetes educator helps, because you really need to be on the patient. A lot of these patients have a fear of hyperglycemia because they're so afraid of complications that they keep themselves lower than they ought to be. And to some degree, that takes a lot of hand-holding and convincing to raise their sugars so that they can start sensing their lows again. But I think that this is a lot of education, a lot of hard work, a certain amount of psychology. I think that for people to avoid lows is a big issue, and yet doable if we adjust the targets and then do all of the things that I know Davida can teach us about that help people prepare for lows and then treat them when they have them.
Davida, how can clinicians assess their patient's risk of hypoglycemia, particularly severe episodes?
Well, I think it's a conversation you have at every visit. And I know both Anne and I do that. We have dot phrases that remind us to do it. But it's a conversation during the visit and or during a phone call, video, whatever it is, it says, are you having episodes of hypoglycemia? And then you have to ask more, because a lot of times patients will say, oh no, I'm good until my blood sugar gets down to 40. And actually, you don't think very well if your blood sugar is probably less than 70, maybe for some patients less than 80. So you really have to tease it out and understand what the questions are. The other thing is, while Anne and I both spend about 70 or 80% of our time probably with type 1 diabetes, I don't want people to think that people who have type 2 diabetes who are on insulin do not experience hypoglycemia, because they do. And by the time our patients who have type 2 diabetes are on insulin, they're also in a situation like our type 1 patients where they don't have a lot of beta cell function. They don't have a lot of counter-regulatory function. So they're at great risk for hypoglycemia. So we can change targets. We can look at A1C, but the fact is, even if the A1C is high, the patient has a risk of hypoglycemia. And you gotta ask the question. So every visit, talk to your patients. What are your symptoms? When do you get them? Is there a particular time of day? Maybe it's the patient who exercises every morning And then all day long, they're having hypoglycemia. Well, there are things we can change in their care that allows them to still exercise, but lower their insulin on the days that they're exercising. They need to carry things with them to treat low blood sugar. If you prescribe insulin, you need to prescribe glucagon, where your patients and family members need to know how to use that and always carry something with you. But it starts at the visit. It starts with the healthcare provider. It starts with the educator. And you always have to ask those questions about hypoglycemia. Are you having it? What does it look like to you? What number do you have? And how do you treat it?
And Anne, once a patient has been deemed to be at risk for severe hypoglycemia, how do you prepare that patient for potential episodes?
Well, first of all, as Davida just said, everybody who's on insulin is at risk for severe hypoglycemia, whether they have type 1 or type 2. And patients who are on sulfonylurea agents and some other oral agents are also at risk. And so the first thing that I do, again, I am lucky enough to have diabetes educators with whom I work who can do a lot of this because it takes time and it takes education. And in clinic, when I'm busy, I actually often don't have time because I'm dealing with other things with the patient. Although every single time I forget to discuss hypoglycemia, I think of Davida because I know that she remembers. And in the old days, I used to have people fill out a form in the waiting room about hypoglycemia so that I'd look at it when I saw the patient so I'd know. But now when I do telemedicine, I don't have that form because it's just done more abstractly. I'm not with the patient. So I think the first thing is that people need to be aware of it. They need to be aware of the circumstances under which it can happen, but they also need to always carry something with them to treat it. And I want people to carry with them some simple carbohydrate as well as glucagon. And I also want to make sure they have glucagon that their partner or whoever they're with would know how to give them, because the patient isn't giving glucagon to themselves, it's somebody else. And so if it's in the bedside table in case it happens at night, that's great. But again, the person who would give it needs to know where it is, and the person who would give it needs to also be trained. And the newer kinds of glucagon are much, much easier to administer than the old forms, but I still think a little bit of teaching is really good for that person. So when they panic, they don't miss it. I just had a patient who came in and said that they'd had to call the paramedics. And I said, well, did you have glucagon at home? And of course they had glucagon at home because I did what Davida says. And I had them all prepared. And I said, well, why did they have to call the paramedics? And he said that his girlfriend got so panicked that she shot the glucagon into the air and didn't give it to him, and then couldn't find the second glucagon. And, you know, these things happen. It's scary to see your loved one unconscious and maybe having a seizure. I mean, it's difficult for everybody. And as all of us know, you know, we've had people have severe hypoglycemic episodes in all sorts of settings. I've had moms have severe hypoglycemia in front of their kids, and they hate that. They feel humiliated. They feel out of control. They feel like they can't take care of their child. It's just horrible for people to have that sense that they're not strong enough, that they're not healthy enough. I want people with type 1 and type 2 diabetes on insulin to feel just like anybody. I want them to feel in control. I want them to feel good. And yet this hypoglycemia lurks. And that's why we have to be so careful about discussing it and educating patients around it.
Today, we're talking with Davida Kruger, a certified nurse practitioner in diabetes at Henry Ford Health in Detroit, Michigan, and Anne Peters, a professor of clinical medicine at the Keck School of Medicine at the University of Southern California. This is a special sponsored episode on hypoglycemia in partnership with Purdue University College of Pharmacy and the Academy for Continued Healthcare Learning. Please visit the tools and a CME quality improvement activity at preventhypotoolkit.org. That's preventhypotoolkit.org, and that link is in the show notes. Davida, we now have second-generation glucagon formulations for patients. Can you discuss these and how you select one for an individual patient?
Absolutely. So we believe in shared decision-making, which means that I can suggest things, but that the patient ultimately, I always say to my patients, I don't go home with you at night, and that's a good thing for you and a good thing for me. But I try to offer them something that might fit better into their lifestyle. So we have the emergency glucagon kits. We call those the little red boxes. They've been around on the market for quite a while. The problem is they have a lot of steps that have to occur. And for the person who is going to administer them, and they're already stressed out about watching what's going on with their loved one, they don't remember, even though the directions are in the lid. They don't remember how to use it. You have to draw it up. You have to mix it. There's a needle that you can see. And so the second generation, which is what we hope all of the commercial as well as Medicare and Medicaid will approve if they have not already, is either nasal, which is a little device that is put into the nose and squeezed, or the pre-filled. So they're patents, you take off the lid, the glucagon's in them, you never see the needle, you literally press it onto the skin, you hear some clicks, and the glucagon has been administered. So there's 3 second generation, and we really hope that everyone has an opportunity not only to get it, but never have to use it. But they do need to know where it is. And I think really quickly about a story that I had a friend staying at my house who had type 1 diabetes and had a seizure. And I never asked her, where was the glucagon? And I couldn't find the glucagon while she was seizing. And I'm a trained health professional. I had to call EMS because I didn't ask the question. She didn't tell me where it was. So that is absolutely the thing we have to make sure is not only that the people that might be using the glucagon know how to administer it, but where is it? Because if you know how to administer it, but you can't find it, that's of no use to anybody. But the new generations are so simple, easy to use, and we really do try to move everybody to a new second generation.
And despite the availability of these different glucagon formulations, evidence suggests that many at-risk patients aren't prescribed glucagon or don't get their prescription filled. What are the barriers that prevent patients from receiving glucagon?
I think that there are many barriers, unfortunately, and one is that people just don't have the time to think to prescribe it. It's not a medication you're going to take every day. In fact, it's a medication we hope you never have to take, but it needs to be there. And most patients, or at least many patients with diabetes, particularly with type 2 diabetes, are treated in primary care. And when a primary care clinician is seeing a patient, there are many competing needs. And frankly, all I do is diabetes, and yet I forget to say, do you have an unexpired glucagon kit at home? And so I really feel that it's hard, and I wish there were ways that it was easier to remind me to make sure somebody has an active way to give glucagon at home. And another barrier, frankly, is coverage, because what I do is what Davida does. I ask patients, but also their partners, what kind of glucagon, of the second generation glucagons, they'd prefer, whether the intranasal or the pen form, and then prescribe it. But not all insurers pay for both. And so if someone goes to the pharmacy to get it and there's a pushback, they may not pick it up because they're like, well, I don't really need this to live. I need my insulin to live, but I don't need the glucagon. So I find that there's insurance barriers, which have gotten less, but nonetheless, you still have to deal with. But also, I'm telling you, it's harder to remember than you'd think. Having this conversation always makes me aware of my deficiencies. So I'm the first to admit I'm not the greatest at this. I just wish I had a way that I knew when somebody needed a glucagon prescription. And some of my patients remember, but if someone hasn't had an episode of severe hypoglycemia, they may not remember to ask for it. But then when they have one, then of course, I get all motivated again and remember, but then I forget again. And it's not forgetting so much as I'm not being prompted. And it should be part of my checklist. And again, as Davida says, when there's hard things going on, you're talking with a patient about, the patient she just is talking about who's given an unintentional overdose of the wrong kind of insulin. Those are the kind of things that take our attention away. And I'm sure in that patient, Davida is sure that they have glucagon at home, but it's just, I'm telling you, I understand everybody's issue in terms of doing this, and yet we all have to do better. And I just wish we all had a Davida to help us, but I don't, at least not that way. And so I just have to keep reminding myself, ask the patient if they have unexpired glucagon at home, and if they don't, make sure they have it.
So Davida, can you tell us about the quality improvement CME activity and accompanying tools that you develop with Anne for providers? And this can be found at preventhypotoolkit.org.
Well, thank you. Yes, absolutely. So we've been working on this, I think about 6 months or so, and we've developed a CME program that people can still view, a case-based program where people that participated, actually, we had cases and we talked about different ways we could handle or better. And I would add that, one of the things we also talked about is what Anne just said about how do we trigger ordering the glucagon. And the biggest holdup is I order it and it isn't picked up because of cost. That's what I find to be the biggest issue. And then we've also have some different assessment tools and guides and alerts at the website that you mentioned that providers can go and look at it and add to their practice that can help them understand how to prescribe, utilize, and educate your patients to use glucagon as needed. But it's a very important fact, and we're all in the same situation where we want to make sure the patient has what they need, and they don't always have what they need. And also, if they have to call EMS, if the cost even to get EMS there and get to the ER, it is much better on everyone involved to be able to have glucagon at home. But it's a great assessment tool so that you can talk to your patients about the risk of hypoglycemia, prevention of hypoglycemia, treatment of hypoglycemia, and utilization of other tools.
So we have a special sponsored episode today on hypoglycemia in partnership with Purdue University College of Pharmacy and Academy of Continued Healthcare Learning. Please visit the tools that Davida talked about and a CME quality improvement activity at preventhypotoolkit.org. And that link will be in the show notes. And I'm going to ask each of you one final question and really just your take-home messages to the KevinMD audience. So Davida, why don't you go first?
I think my take-home message is that hypoglycemia is actually more prevalent than we think. And it's one of the rate-limiting things to get people to treatment goal, and probably the things that keep both the provider and the patient awake at night. And so preparing the patient with the tools they need, asking the right questions, really goes a long way in helping manage diabetes and safety for our patients.
And Anne, your take-home messages.
My take-home message is that, first of all, mild hypoglycemia is more common than people think. And we haven't really touched on it, but it's very important to have people not only prepared for treating mild hypoglycemia so it doesn't become severe hypoglycemia, but also how to take the right amount of carbohydrates so they don't rebound high and then dose again when they're high and then go down low again. So I think treating mild hypoglycemia effectively and educating around that is step one, in addition to step two, which is just remembering to make sure your patients have glucagon, that it's in a place where somebody else would know how to find it and someone is comfortable administering it. The bottom line is as Davida noted, if all the wheels fall off the cart and there's nothing else to do, you have to call the paramedics because this is a life-threatening emergency. But for many, many reasons, hopefully people have the glucagon, it can be administered, and that doesn't have to happen. But my other caveat is that in seniors, some of them may end up with more than just hypoglycemia. They may end up with a cardiovascular issue. There may be other things going on because they have known cardiovascular disease. And in an episode of severe hypoglycemia, your evaluation after that might need to include other issues, and just make sure that for some of these elderly patients, you look at all of it besides just the episode of severe hypoglycemia.
Davida and Anne, thank you so much for joining me today. Please visit the CME Quality Improvement Activity at preventhypotoolkit.org. Thank you so much for your time and insight.
Thank you.